Hello, I'm Rob Storey, Professor of Cardiology from the University of Sheffield in the UK. So I'm joined today by Antonio Colombo from the Columbus Hospital and San Raffaele Hospital in Milan, Italy. Welcome.
Thank you.
And Jean-Philippe Collet from Hospitalier Pitié-Salpêtrière in Paris in France. Welcome.
Hello, gentlemen.
And Jeff Dalen from Acumetrics, the Chief Scientific Officer there in the US. Welcome, Jeff.
Thank you.
So we've seen quite a body of evidence emerge over the last decade in terms of antiplatelet drug response and the implications of that. And this has become quite a concept in terms of actually measuring the response to a drug and seeing where we are. Antonio, what's your sort of take on this concept and where it's at now?
You know, this issue of platelet responsiveness has been going on for a while. There is some papers from Florence, from Italy, the group of Antoniucci, Gensini. And in the last 3 or 4 years, one consistent finding is that it's better to be a good platelet responsiveness person rather than a bad platelet responsiveness person if you have a stent, and even if you don't have a stent, provided you have active coronary artery disease. So I think in the ADAPT study, which was just published in Lancet by the group of Greg Stone, pretty strongly confirmed that if you are a good responder, you do better. Then there are other stories about bleeding, etc., but then we will have time. So I think one piece of evidence is responsiveness, if you are good, is fine. If you are bad, is not very good.
Jean-Philippe, where do you think the sort of concept has got to at this stage in 2013?
Well, the concept is very seducing, and I think that we live in a society where we measure everything. And we have known that, you know, for more than 20 years with the lipid story, and we started to measure everything, and finally we ended up with, you know, one biomarker which is very strongly related to outcome, and that we use everyday practice to tailor treatment. So I think that this concept should apply to, you know, antiplatelet treatment. And the question is, and it's a kind of philosophy question, do we have the wrong drug or do we have the wrong test? So, and you know, this is where we are in terms of investigation. And as Antonio Colombo raised, we have quite consistent data showing that it's a very good marker of risk when you measure platelet reactivity. But it's a complex threat. It tells you about, you know, antiplatelet treatment response, but something else, and this is what we need to figure out.
Mm-hmm. And in terms of the treatment options in antiplatelet therapy, what's the range of therapies you're accessing now, Antonio, in the cath lab?
You know, we have a different school of thoughts. We have the classic clopidogrel, and we know that some people don't respond well to clopidogrel. We have ticagrelor, maybe one size fits all. You should give to everybody ticagrelor, and we get rid of the problem. But or prasugrel, with the same concept. But what the study ADAPT has shown, and is really nothing so new, because the German group of Sibbing already published these findings. If you are a good responder to clopidogrel, you also have a high risk of bleeding in general. So I'm not so sure that makes a lot of sense to give a more potent drug to someone who is a good responder. It's very logical. We have never been able to prove this. But I think a good scientist should try to stick to what makes a lot of sense. And if I had a PRU or a light aggregometry with a value of 5, 10 on clopidogrel, I would be very nervous to take 10 milligram of prasugrel.
I agree.
So I guess in terms of, you know, those patients, if you've got a drug response on clopidogrel, particularly in the sort of elective PCI setting, then you can feel more relaxed that you know, the drug's doing what it's intended to do.
You know, one problem is that we are dealing with a lot of middle-of-the-road situation. If you have 200, it's better to have 200 or 250. You know, when you go to those subtleties, but I think it's better to have 10 rather than 350. So let's start first, get rid of the extreme.
So the sort of PRU range there you're sort of suggesting gives you a good sort of feel for where you're at in terms of your clopidogrel response, and you feel comfortable using that in terms of managing your patients?
I do so, especially maybe because I am exposed to complex stenting. Patients that I see are usually referral with diffuse disease, not good candidate for surgery. So I really have to be very more concerned about having the maximum protection. But in those patients, I pay a lot of attention, especially when I get these extreme values. I will be very nervous to leave on clopidogrel someone who got 5 stents, long diffuse disease of the LAD, and if the PRU or another test is way off the line. I will, especially for the first 2 or 3 months, which is a risky period, I prefer to use a more potent platelet inhibitor.
So clearly the complexity of the case and what you perceive as the risk of stent thrombosis in that patient is influencing your approach to this whole issue of clopidogrel drug response.
Yes, and unfortunately those issues are difficult to homogenize and to capture in a many thousand patient randomized study. Gravitas is one example. The Arctic study is one example. These are selected patients. I was, before this meeting, I was re-looking at the Arctic, which seems a contemporary study. They use prasugrel instead of double dose of clopidogrel. But if you read carefully, even in the Arctic, they didn't use prasugrel in every patient. A lot of patients got higher dose of clopidogrel, and that's something that pollutes the results.
So Jean-Philippe, so you led the Arctic study. Do you want to sort of comment about how the findings, how we should interpret the findings of that when we're sort of, you know, faced with this issue, as Antonio describes, a very complex case that's of high risk? How do we marry up those two?
Yeah. Well, there is, like, you know, a gap that need to be filled up, because in the Arctic study, it is as, you know, we tested 2 different types of strategy, you know, using the test at the time of PCI, so before stenting. And there were consistent data with prior studies showing that about 1/3 of patients were non-responders. And so before PCI, they were, you know, reloaded with clopidogrel, and I agree that very few had, you know, prasugrel. And they had also, in 80% of them, GP2B3A. So, and this is just to avoid pre-PCI events, and this was done. And 14 days later, we had a different picture, because, you know, the number of non-responders was halved. They were, you know, treated differently. About 80% were reloaded, and about 20% to 30% had prasugrel for the long term. But by doing that, there were no impact on outcome. And so we did some PD analysis looking at what's happening in the patients who got the test. And when you pull the patients, you know, who are non-responders at the time of stenting, and 14 days later, and you look at their outcome, there is, you know, a clear difference between high on treatment platelet reactivity and good on treatment platelet reactivity in terms of outcome. It means that the non-responders have a clear higher risk in terms of the primary outcome. But when you look at now, you know, the distribution of the events, you know, according to the PRU, and you look at patients without and with events, you have exactly the same distribution. And what is interesting is exactly the same finding as with the Trilogy trial, and there was some PD analysis and showing exactly, you know, the same trend. So the point I would like to raise is that when you measure the PRU, you measure the risk of the patients. But still, you don't know whether intensifying the treatment will end up with less events. And I mean, this is, the point. And interestingly, in the Arctic study, when you look at major bleeders, there were about, 3 to 5% of these patients. And interestingly, they have a higher platelet reactivity than the other one, because, PRU integrate platelet response, but also the underlying comorbidities. So we were very, puzzled to see that major bleeders have a higher PRU level, and it's very highly significant. So, it integrates lots of different parameters, the measure of platelet reactivity, and we have to sort out, if we can, discriminate patients, at risk of bleeds or at risk of ischemic events.
I guess the challenge in terms of doing a study like Arctic, if you were to sort of enrich for procedural risk, is just actually getting that number of patients, isn't it? So, take 10,000 of Antonio's very high-risk, complex sort of bifurcation disease, long, small vessels, put them into a study, compare clopidogrel non-responders with, prasugrel-treated patients. We're going to see a difference in stent thrombosis, most likely in a well-powered study. Would you still agree that that is a sort of valid concept?
Probably yes, because if you stick to higher risk patients with more diffuse CAD, you end up with elderly patients with more comorbidities, and you end up with the same story. And we have the Antarctic trial, which is ongoing, and typically these are 75 years old patients or even more, and they have been stented in the context of ACS, so it can be STEMI, non-STEMI, whatever, and they are randomized to have 5 milligram prasugrel or 5 milligram prasugrel with serial testing, with the idea of having them in the time window of PRU from 80 to 208. And the idea is to prevent bleeds and to prevent ischemic events. But we do not really know whether we are going to be able to uncouple bleeds from ischemic events, because usually the predictors are the same. And this is the issue. So we're going to see in a high-risk patients whether we can get some benefit by tailoring therapy.
Another issue is that thrombosis, and in particular stent thrombosis, is really multifactorial. Mm-hmm. So it's not determined only by platelet. Platelet is very important. I reviewed some cases of patients who had an excellent platelet responsiveness, PRU very low, good inhibition, and they had thrombosis. But of course, they had poor TIMI flow at the end, no runoff. Some other cases, the stent was really badly implanted or had a distal dissection. There is no way you can overcome by being more aggressive on platelet. You need a certain milieu. I always make the comparison with my fellows, like a chair. You need a minimum of 3 legs in a stool to stay up. And even if you make one leg of titanium, if the other leg is poor runoff of paper, the chair falls. So you cannot get upset because platelets are well inhibited and the patient had thrombosis, unless you are really diligent and evaluate the case by case and analyze the associated factors.
So that's a very graphic way of describing sort of Virchow's triad, which is you've got your blood factors, your vessel wall, and your flow. And of course, if you have a dissection, then you've got 2 of those legs on your stool have been cut off. So that's still a very old concept, which is relevant today in sort of modern PCI, that we have to address all these factors, but platelet function being a sort of key part of that, one of the legs on the stool. So that's interesting. How do you sort of think about bleeding risk in your patients with very complex disease, complex bifurcation disease, for example?
The very practical way I try to overcome, because the bleeding risk is a reality. We know that they bleed more patients that are very responsive, but also the other patients, knowing that most of the thrombotic event tends to cluster in the first 30 days. I try to be more aggressive with antiplatelet therapy in the first month and a half. No trial has evaluated this approach. It's not easy because events are rare. We know all the issue of stent thrombosis nowadays. But one way is not to commit patient to strong antiplatelet therapy for long term. The stent after 1 month, 2 months is partially endothelialized, especially second generation stents. So, and even in the most recent trial, at least 50% of the thrombotic events occur in the first month.
Yeah, mostly, yeah. This is the tricky period, yeah. And probably this is why, the study we had, in most of the studies was, one, time point measurements. And we know that, the situation may change, very fast. And this is why we need some more information. And the patient is changing, within the first 10 days after stenting, especially in the context of ACS. Yeah. And so this is why we need more information, more data, and that we have lots of, unexpected events. As you say, even if we are happy, with the way the stent was implanted, sometimes, you end up with bleeds or with ischemic events, and you need to sort out what have happened. And I think that this is why we need this test, to figure out what happened. Is it, related to the treatment, to the patient comorbidities, and how then I can, envision the future.
And what about assessing compliance? Do you see a role there for platelet function testing?
Oh, yeah. And I mean, the best example is LDL cholesterol with patients on statin, or measuring, heart rate, when patients are on beta blockers. And I think it's a very good, example. In 5 minutes what's going on, and you see that this is very important compliance, because we have seen with the Paris registry, which was delivered today, that in those patients who interrupt, on their own, without any medical decision, they get the events, more events, as compared to those in whom treatment was interrupted based on medical decision. And so I think that treatment compliance is a real issue, and that these tests, are a very good opportunity.
And Jeff, you've got some sort of views on the value of the test for assessing whether or not you've got a drug response, be that due to compliance or lack of effective metabolism of clopidogrel.
Yes, and it's very interesting, because I think it's a good point that was raised about the fact that you can have adequate P2Y12 inhibition but still have an event. And this is because there are a number of different ways to activate the platelet, and the platelet is directly involved in thrombosis. And if you take a step back and look at the information that's provided by the test, it's not an indicator of risk. It's not some risk marker. It's directly measuring the drug effect. And the purpose of giving the antiplatelet therapies is to see the pharmacodynamic effect on the platelets, and to be able to confirm that you do have that effect, because it's the pharmacodynamic effect that's associated with lower rates of thrombosis, but also increased rates of bleeding. And so from that perspective, confirming that the effect is present, as Dr. Colombo mentioned, through the ADAPT-ES trial is the latest that's confirmed this. We've always seen and consistently seen that the presence of the drug effect is associated with less thrombosis.
I agree, but to refine your statement, if we really want to know, the treatment effect, then the best is to have also a baseline measure, and for all tests. And in most of the study, we lack, the baseline, measures, prior to the, drug initiation. And this is why it's measuring the treatment exposure, but also not entirely treatment exposure, but something else.
Yeah, and that's a great point because, and that's where there's been some debate too, is because what's more important, where you start or where you end up? Exactly. And most of the data have been focused on where you end up with the PRU. So it's a very interesting point.
Jean-Philippe, how do you see the evidence linking sort of high levels of inhibition with bleeding risk, and do you think that's dependent on the population that you're assessing?
Well, I think it's quite consistent. I mean, as Antonio Colombo mentioned, we have the German data, we have the Greystone data showing that high treatment platelet reactivity and high on treatment platelet reactivity is protective against bleeding, and I think that, and especially in patients with very low on treatment platelet reactivity, it's very risky. And in our own practice, we are measuring almost all patients who are exposed to new P2Y12 inhibitors, and about 1/3 are having low on treatment platelet reactivity, which means more than 90%. P2Y12 inhibition with the Verify Now, which means that they have a PRU average which is below 30. And you ask yourself, well, am I going to leave these patients for like 9 months to such a high inhibition of platelets and end up with bleeds? And we know that in these patients, mostly they are old patients, when they start to have BARC1 bleeds, what they do, they just quit the treatment and then they get the thrombosis. And so this is an issue.
Yep. That's very important aspect, because this in order to increase the compliance, you have to minimize the side effects.
Yeah, of course. Yeah.
It's a very simple approach.
So, and do you think the assay, the P2Y12 assay, is robust enough to actually be able to titrate response? Is that your
experience? We have basically multiplate, we have Acumetrics, and then we have the two more sophisticated light aggregometry and VASP. Most probably the light aggregometry and VASP are close to the gold standard, but we know how, unless you have a dedicated laboratory. So I think for clinical reason, we have to rely on multiplate. Some people complain that they are too sensitive. The rate of poor responder is over emphasized, 30% versus 15%. But in practice, I like to stick to the extreme. If I have 210, 190, 260, I don't really get too worried. I start getting worried when I see 300 and when I see 80, 65. Some elderly patients have 10. I'm very, very worried. I go sometimes to every other day clopidogrel if they have 10.
So I mean, what you're saying there is that the Verify Now, you're comfortable with the range that it covers in terms of the readout, but except that with any test there's a degree of variability, which means that you can't sort of be too focused on sort of small differences.
Small differences, I think that's. But I think when you do a study, you have to analyze the continuum. So maybe I take more the practitioner approach, but I think when you're dealing with individual patients, sometimes you have to become a little bit a practitioner and not become a scientist.
Jean-Philippe, further thoughts on that?
Yeah, well, my perspective is that something is lacking, in the puzzle is whether we could improve, the test accuracy to predict events. And I think this is the big issue. And I'm always wondering, whether in those patients who are on clopidogrel, you just, have one blood sample and you measure platelet reactivity with different tests. And, you look at, the concordance, to define non-response, between tests, and whether you need one test, two tests, or three tests, and what happened, in terms of predicting events. And this is what I'm looking for, to have, a good picture and to see whether we can improve, and whether we should do one sample measurements or serial measurements, and or whether we need to combine tests, in a single measure and see what is happening in terms of clinical outcome. If we want to use tests, to adjust treatment.
Great. Well, I think that's been a really excellent discussion of some of the issues surrounding platelet function testing in relation to PCI and some of the pragmatic approaches that we've come to in terms of addressing the sort of difference between how we deal with our individual patient and what the evidence base can tell us at the moment, and highlighting some of the issues for the future where we may improve the evidence base to guide us further. So Antonio, Jean-Philippe, Jeff, thank you very much indeed.
You're welcome.
Thank you. Thank you for this.